we quick introduction. As many of you know, Dr. Edward Kasarskis has been running the ALS Clinic and Center for Excellence for decades. I think, were you there when Riluzole came out, which was in the early 90s?
No, I don't really think so, but pretty close, I guess.
So, since Riluzole came out and before the two latest medicines came out, the survival of ALS patients increased, even though there were no new drugs on the market, and the survival of patients in the absence of new disease-modifying therapies has a lot to do with the other types of care that is provided for ALS patients. A lot of it has to do with NIV, non-invasive ventilation, but as Dr. Kasarskis has found in quite a bit of research, he's basically leading the field in nutrition in the care of patients with ALS. And we think that probably nutrition has quite a bit to do with survival of patients with ALS. And so I'm going to let Dr. Kasarskis take it from there. And thanks again for presenting.
Yeah, I'm sorry that we had so many technical difficulties here working with BlueJeans, which is not a platform I'm obviously familiar with. So we've got some delay in time to get started, so I apologize very much for that. But let's get started with this. So I know, Martin, we've got a couple of required disclosures here, and the next one I think is for people to get CME credit for this. I believe is there you go. I think Lily has put that into the emails and stuff, so we can just go ahead. So this is a question slide that we're going to try to answer toward the end of this grand rounds. So we've got two individuals here, person A and person B. And so the question is which one has ALS and which one is simply malnourished. And so we're going to see if we can work our way through this conundrum here, because to the casual eye, they kind of look the same, actually. So if we go to the next slide, there we go. So these are the goals that you should be able to answer the question. Understand how malnutrition or undernutrition may affect the course of ALS. And then I'm going to use the term energy and calorie kind of interchangeably. Technically, all the nutritionists want you to use energy as far as the nutritional intake that you are able to metabolize. And finally, we'll get into why should neurology types care about this at all. So next slide there. So we're going to start with a couple of case presentations. These are two individuals. You can go to the next slide too, if you would, Martin. So these are two individuals that have ALS. This first person is a 76-year-old woman, and she had the onset of ALS, bulbar onset ALS, November 2021 with some dysarthric speech. So, of course, this is the saga that happens all the time. They go to the emergency room or see a different physician, and somebody thought since she's 76, of course, she's had a stroke. ENT referral was placed, and the ENT physician observed tongue fasciculations and considered ALS. And so she went through the usual sort of evaluation with ruling out structural things and ruling in ALS with EMG and ruling out biopsies and things like that. So if we go to the next slide, please. Yeah, so she had progressive bulbar weakness and more dysarthric speech, dysphagia, Heimlich maneuvers, prolonged meal times, all this sort of stuff. And so by the time we first saw her in the clinic, she had already sustained a 25-pound weight loss over a period of not too many terribly months. And she had other associated ALS sort of symptoms, diarrhea. She had weakness in the extremities and multiple falls, and it was obviously a really bad thing. So the next slide, if we could. Yeah, we don't have to bother with this. Just go ahead. She was pretty simple as far as her past medical history goes. So, yeah. So she was a slender woman. She really was writing on a dry erase board. She had weakness of the tongue, saliva neuropharynx. This is sort of routine for anybody with bulbar onset ALS. And she also had generalized extremity weakness, actually fairly profound fasciculations, pathologically brisk reflexes. So these are the check boxes that we all would be looking for with someone with ALS. So the case essentially says she's got ALS, bulbar onset ALS, sporadic, spread to the extremities, a lot of weight loss. And so she was getting some hyoscyamine to prevent some sialorrhea, and we told her over and over and over again she needs a feeding gastrostomy, and she delayed this. So if we go next slide, please. So finally, she was admitted for a safe peg placement. By this time, she had already lost 40 pounds in body weight, and she responded pretty well in terms of stabilizing her weight after her nutritional intake was improved. So if we go to the next slide, yeah, actually, let's just click through this in the interest of time. This is another bulbar onset patient, had quite a bit of weight loss, and actually the contrast here is this patient actually got her peg tube done more promptly and had some return of her function. So if we go here, this is the first patient's body weight. So she was 160 pounds by history at the time of her onset. By the time of her first visit, she was already down to about 135. She delayed a peg for quite a few months, and you can see the trajectory downward. And after the peg, just over the first month, you can argue maybe her trajectory of weight loss changed. Unconvincing on this slide. She was still losing weight, but she hadn't had a chance to really improve things. The next slide, please, shows the second patient who also sustained weight loss here in blue. And after her peg tube, she stabilized her weight completely. And to some degree, her ALS functional rating scale shows that she was losing function. And after her peg tube, she started improving her function with the last entry here. So if we go to the next slide, so we have a lot of problems with assessing nutritional intake. So, one problem is the business of simply weighing. We have two converging pathophysiologies here. You can get weight loss, of course, because you've got muscle atrophy, because of your motor neuron dysfunction and death in the spinal cord. And so you step on the scale and you are going to be losing weight. Don't forget, we've got in a non-obese individual, perhaps 40% of our body weight is skeletal muscle. So you would say, oh, gee, I am losing weight. Just like, after the holidays, you step on the scale, say, oh, I've New Year's resolution, I've got to lose some weight, meaning you would like to lose body fat. And the other thing is you step on the scale here in the case of ALS, and if you're not eating well, you may well have undernutrition in addition to the neurogenic muscle atrophy. And so which is it? Or is it both in the case of an ALS patient? And then, of course, we have some individuals who have a lot of lower extremity edema, which when you step on the weight, looks like you've gained weight, or at least are stable. So this is one problem with management. The second problem, here's next on the next slide, if you would please. Yeah, the symbolic value of eating. A lot of patients walk around with the idea of if you complete a meal without choking, you're adequately nourished. And I know the good Dr. Brown here has seen lots of ALS patients and knows that this is obviously not the case. I mean, they might be eating, 150 calories, and it might take them, 15, 20 minutes to do that. And that doesn't mean adequate nutrition, but yet a lot of patients think that they have. And then the other confusing thing is when we try to recommend a peg tube, everybody thinks, oh my gosh, this is I'm nearing the end of life, right? And so this has got, again, negative symbolic value for a lot of patients. So next slide, if you would, please. So the third problem, the real big problem here is that chronic undernutrition, malnutrition, can cause accelerated loss of function. And toward the end of this talk, I'll touch on the famous Minnesota study of experimental starvation in adult humans. And this was clearly the case. These individuals who underwent, voluntary weight loss suffered loss of function. They suffered muscle atrophy. And, in this context, malnutrition means the patient is not meeting their energy requirements by the oral route, which is actually the indication to get a PEG tube. So if we go to the next slide, we've got all these problems here. And the question, of course, is how many calories does an ALS patient actually need? And when does an ALS patient need a PEG tube? So we're going to review here how some of these things have now been answered. So the goal here is to maintain energy balance, meaning the amount of, this is for all of us. This is not just an ALS patient. This is anybody. You would like to balance your food intake with your energy expenditure so that you neither lose weight nor gain weight. So this is sort of a lifetime goal, if you wish, day by day of what we're doing, is to manage supply and demand. So if we go to the next slide, so these are going to be a bunch of questions. You're going to be seeing this slide, and I think Martin, you'll be able to keep these slides. So if anybody wants to see them in a more leisurely way, they could do that. But we're going to be going through how do we answer these questions about energy needs for someone with ALS. So if we go to the next slide here, the next slide, please. Whoa, yeah. So here's visually some of the risk factors for malnutrition and ALS. It sort of was inferred with the two case presentations at the beginning. First off, this man here has got upper extremity weakness. I'm asking him to raise his wrist up to, and he can't. This is his power. You see the extremity weakness he has. He cannot cut his food, and he cannot bring the food to his mouth to eat. Then this very same individual has bulbar weakness. This guy, you can see, has got some tongue atrophy. He's trying to protrude his tongue. This is as far as it goes. So it's not a shock that once food gets into his mouth, or liquids or pills gets into his mouth, he cannot safely swallow, and certainly cannot safely swallow at the rate he's normally accustomed to. So here we have impairment, interference with energy intake, with food intake. And then this is a graph that is showing measured energy expenditure versus predicted energy expenditure that's referenced to the point of death. So 50 months prior to this cross-sectional group of ALS patients, you see that their energy expenditure, and it's been labeled hypermetabolism, seems to be going up more than predicted. So we have troubles on the supply side and troubles perhaps on the demand side. So if we go to the next slide, please, Martin. Oh yeah, let's go. We're going to talk about the research ways that we answered some of these questions. So let's go here. So these are the components of energy expenditure, meaning how do we burn our calories? This is not specific to an ALS patient. This is any of us. So the total daily energy expenditure here is parsed out as follows. So the guy in bed, this is resting metabolic rate. So this is after an overnight fast. This is without any ambulatory movements. Just what does your body burn in a sort of a basal way? And this is purely driven by the size of your body. So the height, the weight, the age, the sex, and this is the component that's used by all the dietitians, the so-called Harris-Benedict equation, which, if you know those components of age, sex, height, weight, you can compute with great deal of certainty what your resting metabolic rate is. Then the food is, of course, there's a cost for doing business, a cost for chewing and swallowing, and a cost for digesting and absorbing your food, and that's roughly 10% of the food that you eat. So here, if you start thinking about this already in the context of ALS, we went through some of the problems that someone has with body composition with ALS. You have muscle atrophy. Okay, that's from your ALS. That's neurogenic muscle atrophy. What you're going to have lower body mass. So presumably, on the basis of that, you're going to need fewer calories. Then, of course, you're eating less, perhaps, and so your energy expenditure for eating and metabolism is going down. And then, of course, here we are on the right side. This is the number of calories that you are burning for physical activity, for movement. This is the most variable component. And that, of course, is going to change with ALS. So you have every reason to believe that as somebody is progressing with their ALS, they're probably going to need fewer calories than they are if they're going to the gym and working out, sort of thing. So the next slide here is, so how does a dietitian currently measure and estimate your energy expenditure? Well, you get an estimate of the basal metabolic rate, resting metabolic rate. That's the Harris-Benedict equation. There are other ones, but this is the one that's pretty easy to use. You can find this on the web. There's no problem with figuring out what your basal metabolic rate is. And the dietitian will make the best guess of adding how many calories you need based on your occupation, physical activity, or your disease state. So this is the wild card. So if you're on a burn unit and trying to heal up some surgical skin grafting, you're going to be burning a whole lot more calories. So this is how it's done across the board. So next slide here. This is how you could really get to it. And so we did this study a couple of years ago, and it's a doubly labeled water method. So I want to run through this just so you could see how this is performed. So what this involves is the patient drinks this is horribly expensive, I will tell you. So the patient will drink a glass of water that is enriched with a heavy atom of hydrogen. This is the standard heavy water. This is actually very inexpensive. And also a component of the mixture of water that has the oxygen 18, which is the heavy isotope, non-radioactive isotope of oxygen. And so the person in a research setting ingests both of these components of water. It looks like a glass of water, and that's exactly what it is. Overnight, these two forms of water are equilibrated with the total body water. So the next morning you get a sample of body water, which is urine. How convenient. And what the experimental situation was, these individuals went home, did their thing. If they were in a wheelchair, they're in a wheelchair. If they're walking, they're walking. If they're falling, they're falling. If they need help getting dressed, they get help getting dressed. So how many calories does an ALS patient need in their home day by day? And on day 10, you get a second urine sample. And a colleague at University of Vermont, Rup Tandon, and his group actually did the isotopic analysis here on these two urine samples. So if we go to the next slide, this is the result on a single person. These are the data you get. We actually got an extra sample there at day 7, but you can see it's a straight line elimination. In red is the standard heavy water with the heavy water labeled with hydrogen, and in yellow is the heavy water is labeled with oxygen 18. And you say, oh my gosh, all this stuff for this? What is going on here? But you can look and you can see that the two slopes differ ever so slightly. that the 0018 turnover is more rapid over 10 days than the deuterium turnover. And so what does this get us? So the next slide, please. What this gets us is an understanding of elimination of total body water turnover. And you might say, okay, what's the big deal? So the heavy water, the deuterium D2O there, is eliminated only in bodily fluids. The oxygen 18, however, finds its way into the carbon dioxide pool. And of course, that is related to the amount of metabolism. So there are complex equations that will plot out the amount of metabolism that's going on in the body over a 10-day period based on the turnover rate, the elimination rate of these two isotopes. So in the next slide, for a single individual, what you get is a datum that says, okay, ALS patient number 3, you burned 27,480 kilocalories over 10 days in your own home doing your normal thing, or something like 2748 calories per day. This is it. This is it. This is a very solid number. This works across the animal spectrum. It's been done. This is sort of the gold standard of how many calories you have burned, how to determine this. So in the next slide, once you have this, then if we continue on with the next slide, please. Once you have this for a single person, you know how many calories that person burned. And then the statistical modeling involved finding out what other factors might influence this. And so the route we chose was to establish the basal metabolic rate based on their current bodily metrics. And then, as it turns out, 6 questions from the ALS Functional Rating Scale successfully modeled the amount of physical activity for this one individual being cognizant of the hypermetabolism question. It's all sort of rolled in there together. So if you go to the next slide, the things we determined for statistical analysis was body composition with DEXA scanning, a bunch of clinical assessments of spasticity and all these other things, FVC, forced vital capacity, ALS functional rating scale, a bunch of physical activity measurements. We actually used accelerometers. I'm working on a paper on that currently. And then business of all sorts of different laboratory determinations. The thing that actually worked over and over again, we did approximately 40 different statistical models on this, and the thing that really mapped most strongly was their functional abilities with the ALS functional rating scale. So I'll show you how this works. If you look at this histogram, this is the difference between measured total energy expenditure with the doubly labeled water minus the basal metabolic rate, which is the Harris-Benedict equation. And so the red arrow shows that there are some individuals who are really burning calories, burning energy at the level of the Harris-Benedict equation, and actually some that are less than this. If somebody is on non-invasive ventilation, for example, they're not burning calories to breathe. If you have somebody on a trach and a vent and a peg tube, oh my gosh, they could be burning hardly any calories at all. We had a man a couple of years ago who was approximately my height, about 6'1". He weighed 220 pounds. He burned, by measurements, other measurements, 750 calories a whole day because he wasn't doing anything. And then if you look on the right side of this histogram, you see there are some ALS patients who are more physically active, and they're burning 2,000 calories above their resting metabolic rates. So we have a singular diagnosis of ALS, and from a nutritional standpoint, you have quite a spectrum of energy expenditure depending on their level of physical activity and the level of their hypermetabolism, which is all blended into this analysis. So if we go up further, so I don't think we have to worry about this, where we have about 250 individual determinations of doubly labeled water in 80 ALS subjects. And you can go ahead because we don't have time for this, but there's the total energy expenditure. Harris-Benedict equation, 6 questions of the ALS functional rating scale, -168. These are the equations that appear in the paper. If you go to the next slide, whoops. So we developed an app. I won't have time, given the technical difficulties here, to show you how this works, but you can copy this down and easily plug into the web, and you'll see how it works. It's very intuitive. So if we go ahead to strategies needed. So I already mentioned what the indications are for a feeding tube. These are time-honored by the gastroenterologist. So if your energy intake by the oral route, meaning the way we all eat, is chronically less than your energy expenditure, and also if you have a normally functioning GI tract, so meaning you are able to absorb your food, then there's not much discussion here. You need a PEG. So, you know, this would be very obvious if you had a cancer patient with oropharyngeal cancer and couldn't swallow and, you know, do functioning gut. Of course you need a PEG. That's how you're going to get your energy and your hydration and your pills. That same argument here with ALS. And if you looked at the first 2 patients and saw the trajectories of their weight loss, you can see that that was likely the case. Okay, let's go to the next slide. So, you know, we have currently the recommendations for PEG are in the ALS world are done by indirect risk factors. You saw that in the slide of the patient that I showed you with ALS. You have weight loss, length of meal times is long, they have difficulty with chewing and swallowing safely, and they need assistance for eating. So these are not directly addressing, are you getting enough nutrition, yes or no? These are risk factors for failing your nutritional intake. So if we go to the next slide, please. This is a recent paper that Ruptandon and I did. So this is the caption of the slide, is what happens when an ALS patient loses weight, because this is the convenient thing that ALS patients can do. They step on the scale and their weight is stable or increased or decreased. So let's look at this. If your weight is decreased, FM is fat mass, LBM is lean body mass, essentially muscle. 100% of people will lose fat mass. And if you think about this, this is sensible, because why do we really have body fat? You know, this is a portable source of energy for all of us if you happen to fall behind on your energy intake for a few days or for a short period of time. So as you are undernourished or have semi-starvation, first thing, of course, you do, glycogen goes. Second thing is fat mass goes. And then also lean body mass is also hauled on as a metabolic source. So here, this is an ALS patient. If an ALS patient is decreasing in their body weight, 100% of this 102 patients we had in here, 100% of them, every one of them had a reduction in fat mass that we measured. And almost half of them had a reduction of lean body mass. So lean body mass could be due to the severity of ALS, no argument there, but it could be due to undernutrition. Now, if you flip over to the right side, where it says increased body weight, so this is like the person who had their PEG tube placed and was getting nutritionally rehabilitated. Fat mass, none of them, 0%, lost fat mass. So that makes metabolic sense. You're well nourished, you're storing fat, and or at least you're keeping your body fat. Great. And here, at this point, nobody in this small sample, 41 patients, nobody was losing lean body mass. In the middle is the confusing part. People say, well, my weight is stable. Still, almost a third of them, 20%, lost fat mass. So these were individuals, even though they were stable body weight, had negative energy intake. And some of them lost lean body mass. So this is the spectrum. I mean, we can say with confidence that if you looked at the trajectory of your fat mass loss, that will probably be informative for you in terms of, is this person chronically undernourished, yes or no? So if we go to the next slide. So this is a slide showing the survival of low body mass index. So this essentially replicates what Sabrina Pagnoni showed, 5-10 years ago. So in the group here with a low BMI of less than 20, survival is not as great as if your BMI is around 30. And this replicates Sabrina's paper very, very well. So, the sweet spot for survival in ALS, this is ALS patients. We're not talking about chronic cardiovascular disease 20 years down the road. We are talking about how does the ALS patient get through the next couple of years. So if you are really a very slender ALS patient, your survival is not as robust as it is for somebody who's a BMI of 25 to 30. Above 35, you have adverse other causes of death in an ALS patient, just like anybody else. But so this shows that. So if we go to the next slide, if you would please. This is now focusing in our paper, looking at computing body composition. So on the left side, this is kind of a little bit confusing. This is fat mass, and on the right side is lean body mass. And this was the group of patients we had were divided at the median. So what this is showing is that if your rate of fat mass loss was high, meaning above the median, over 6 months, your survival here in the solid line was less than if your fat mass loss was slow, which is the dotted line. And so this is a kind of the mirror image of the BMI sort of story, that if over a 6 month time in the clinic, there's nothing fancy going on here. They're in the clinic and computed body composition. If you are losing fat mass as an index of undernutrition, that's what this is saying. You are losing fat mass more rapidly, your survival is less. So if you are losing fat mass rapidly, this is again an ALS patient. We're not talking across general population here. We're talking about ALS patients. Over a 6 month time period, lose fat mass rapidly, your survival is less. And correspondingly, you have a smaller or greater lean body mass weight loss. So this is telling us something about how to manage ALS and nutrition and ALS. So if we go to the next slide, I'm trying to be mindful of the time here. So this is a great study that will never be replicated. This has been popularized in a book called The Great Starvation Experiment. So if you wanted to read about this study, that would be the place to read it. The scientific data are reported in a 2-volume book called The Biology of Human Starvation. This is not light reading. This is just table after table after table of information. But what this was a bunch of conscientious objectors in World War II that volunteered to participate in a study of starvation. And so here is one individual. This is another component of this book. This is done in the 1940s, before IRBs and before you didn't put people's names in here. So Sam Legg apparently volunteered for this study. So here he is on the left as a young buck farmer. You can tell he was a very slender man to start out with. Over a 6 month period, this study design was to restrict calories day by day, chronically, slowly, so that at the end of 6 months, they would be at 75% of their initial body weight. So this would happen to any of us here if you were chronically undernourished. Nope, yep, keep it here. Oh, you're going trigger happy. Okay, there you go. So this would happen to any of us if we also were chronically undernourished. This was good quality food. It was just in restricted amounts that was carefully controlled in the study. And the graph that I abstracted here shows in green their loss of body weight. This was the variable that was controlled. Their body composition shows loss of fat mass in yellow down to 20%. So that makes sense. You can see the picture on the right. This guy does not really have much body fat on him. But also buried underneath this was he lost skeletal muscle mass. Look at him. The reason this study was done was how to refeed people that were coming out of concentration camps. So there was a scientific purpose to this whole thing. But you can tell from the standpoint of ALS, you've lost fat mass and you have lost lean body mass or skeletal muscle mass. And this is simply for lack of energy intake chronically over a 6-month period. So if you go to the next slide, in the context of ALS now, an old study, 1995, Mazzini in Italy, studied people that volunteered, that chose to get a PEG tube versus a control group who refused to get a PEG tube. And so here's the probability of survival on the left side. You can see people who had a PEG tube survived better. And the complicated thing on the right is the interaction between forced vital capacity, meaning respiratory support, as well as nutritional intake. So these two things go hand in hand, just like Dr. Martin said in his introduction. So if we go to the next slide here. So this is the thing I want you to write down. We won't have the time to fiddle with trying to get it linked, but go to the next slide. This is on the web. This is a nutritional calculation that will give you, when you enter in the data that are needed, it will give you their calorie requirements. It'll give you the hydration requirements. It'll give you the body composition. This is based on a research that was done for ALS patients. So this is not you and me. This is for an ALS patient. So if we go to the next slide, if you would, please. Yep, let's go. So this is the question here. Person A is from this Great Starvation experiment. This is one of the guys who volunteered for chronic undernutrition, and he's in their metabolic lab doing a bunch of different tests. This is horrible muscle atrophy, and this is a healthy man. He's like 20-some years old. He was a farmer. Come on, give me a break. This is just undernutrition. It would be hard pressed just by inspection to see him, how much different he is versus this ALS patient of mine here on the right, which is person B. This guy has a mutation in the fuse gene, but nonetheless, you've got ALS, and they're like carbon copies. That's the point of all of this. So how much of the atrophy that you see with person B is just because he's got really horrible, bad, fast ALS, and how much of this is a contribution of undernutrition? That's exactly what we're trying to do. So if you are in the position of managing these patients, you're looking at person B and you are saying, okay, maybe 10 or 15% of this is energy insufficiency, and this will change over a period of time. And this guy, if he had a PEG tube and stabilized his body weight, functionally, he would probably be somewhat better than he is currently. Now, the question I had here, of course, is this relevant to other neurodegenerative diseases like Parkinson's and Alzheimer's and stuff like that, where it is conceivable that energy intake, nutrition might be affected? Speculation. I'm not aware of any study with doubly labeled water where this has been measured. So to be determined. So next slide here. Yeah, these are the people who worked on the nutrition study, and I already mentioned Brooke Tandon up at University of Vermont, and this is most of this has been published except for the accelerometer part, which we're still working on. So I think that may be one more slide. Oh, yep, there we are. That has nothing to do with nutrition. I don't think this is an edible plant, but it's pretty. So I'll be happy to answer any questions that have come up. And again, I apologize for having difficulty getting loaded on and a bit of a rush presentation, but we ended up on time.
All right, thank you for that wonderful.
Whoops, I'm not hearing you there, Martin. I'm not sure what the. I don't think you have your headset adjusted.
Can you hear me now?
Yes. I can.
Okay.
Like an air traffic controller there or something.
That's right. Yeah, God help us if I'm an air traffic controller. So thank you very much for the very informative and pertinent talk. I had a question about the total energy expenditure. Was that correlated? You would think that someone with spasticity would burn more calories. I mean, the people who have a lot of spasticity will just tell you they're just fatigued. They feel weak, but it has more to do with fatigue. They're just constantly burning calories from their spasticity. Did that correlate in the study, or was that looked at? Who has more upper motor neuron or more spasticity, and who has just lower motor neuron?
Yeah, we sort of invented our own. Well, you're familiar with the existing spasticity scales, which are not very linear. They're not very good. I mean, you've got really, really bad spasticity or attempted varying grades of it. So we applied the one scale to that, and that did not enter into the statistical models. Really, we did our first model was all the variables, which were 40 or 50 variables. And, the things that came out over and over and over and over again were some approach to doing body composition, which makes sense. And then some approach to energy expenditure, which is what the easiest one that turned out to be the 6 questions for the ALS functional rating scale. And so those were the ones that kind of overshadowed all the other things. So spasticity, you would think, would influence it a little bit. Fasciculations, if you had ongoing fasciculations, probably also the same thing. They were just not that big of a component compared to some of these other things. Now, I think they're all blended in together when you did the final statistical modeling with this ALS functional rating scale, because you would imagine if somebody has spasticity and they're still trying to perform a function, let's say walking across the room or something like that, they may well be burning a lot more calories with spasticity than they would be if they did not have that. I think that is all sort of wrapped up in our final equation here. Again, this is applying only to ALS patients and not to other diseases. So I have to emphasize that over and over again.
Yeah.
So, we looked at it, and it was not a major factor.
I was also impressed with the diagram that had the people who had lost weight, who had stable weight, and who had gained weight. In the population that gained weight, in a 6-month period of time with ALS, they lost 0 lean body mass, which is unexpected, I guess. In a disease like ALS, loss of lean body mass would probably be the expectation, and they lost 0.
I would agree with you, but I mean, to some degree, that's a small sample of 40-some people, and it's results that we found, it would be really important to have that replicated in other populations to see whether that's the case. But I think the contrast between weight loss and weight stabilization or weight gain is pretty clear in this group. I think overall we had something like 200 and some people that there's just clinic patients, right? There's nothing special about them. They were not on any particular drug, and this was just them either losing weight or not losing weight. But I know you in your patients, they'll say, "Oh, gee whiz, I'm doing fine," but I mean we're kind of real big about not. Well, I should, before I make that comment, I mean, we're big about them maintaining their weight or increasing their body weight. You have people that come into their ALS with an elevated BMI, so that they're kind of heavy set, and they're saying, "Oh, well, I got a diet, to lose weight and get back to," they're getting religion that they have to diet. It goes on and on and on. So there's so many different social factors here that come into the business of food intake and what it means for these people. So that's another thing that we're working on, to tell you the truth, is to try to get proper vocabulary of how to engage ALS patients with the importance of nutrition. Just because there's a lot of emotional baggage on this whole thing, and we're not even putting our toe in the water here about all the online nutraceuticals and how much CoQ10 you should take, and acetylcysteine, and it goes on and on and on. So, there's a lot of smokescreen that's going on around this whole area, and of course, family members from will search Dr. Google and try to come up with stuff. So it gets to be really pretty muddled, as you know. So there's a lot of impediments to getting a PEG tube, and I mean, a PEG tube is not an end in itself; it's a means to an end, and that's exactly what I think we have to demythologize here a little bit. We've had sort of a focus group with a bunch of ALS patients who were really insightful about this whole thing. They made the comment that a PEG tube was the first thing they had done to them, meaning a surgical procedure done to them. And this by itself was a big deal. So, we got lots and lots and lots and lots of stuff to improve our communication about this with patients. So, to be determined. We're not there yet, that's for sure.
Yeah. So now it looks like now we have a number that we can use, or a measure that we can use, an objective measure to tell us when we think it's time to get a feeding tube. But the bigger decision is, when is the patient ready to get a feeding tube?
Sure.
It's always, I think it's helpful to say, are you putting the fork down before you're full, or are you ever having to stop a meal because it just takes too long, or it's too stressful, or it's too much work? And that's usually a nice way to sort of lead into, well, here's one solution, but it is a decision point, and it's a big deal for getting a feeding tube. It's actually, I think it's harder to convince people for a feeding tube than it is to try NIV, because that's not implanted. It's not a surgery.
That's right. Yeah, I would agree with everything you're saying, and I think to be tested, again, to be determined, is whether or not, if we do follow somebody's fat mass over time, and if we see that metric going down and intervene, or say, look, this is clearly not going well for you. You need another source of nutrition. I think we would be we would be on the right track. And that's a study that I think we need to get going here this coming this is a New Year's resolution 2023. We need to get something like that going to see if that actually plays out in the field. You would speculate that it has to be just based on the Great Starvation experiment. I mean, that's how our bodies work. But to actually prove it in a disease state with real people is the next task, I think, to see if that really will influence survival and influence function. So that's a to be determined thing. So, yep.
All right. Okay. I think it looks like my video is frozen, so that must mean that our time is up.
There's a message there. I think our meter has run out here. So I guess, Martin, next time I'll see you in Louisville. I mentioned that I'm immobile now because I broke an ankle. So that's why I'm doing it remotely here. Otherwise, I would be with you. So anyway, right. There we are.
We appreciate it. All right.
Yep.
Thank you.
Sure. Take care. Have a good day.
Bye-bye.